Hello, welcome again to another episode of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Cardiology. I'm Seth Bilazarian, a cardiologist with Pentucket Medical, and I'm here with my associate, Dr. Sunny Srivastava, to talk about a subject that does not come up that frequently in cardiology, but is very important when it does, and that's the issue of a patient who is pregnant, a woman who is pregnant, who has either a history of heart disease or is pregnant and has some kind of a heart issue that's identified, which may be a heart murmur or some other kind of issue, a heart rhythm abnormality, something that we really deal with without any kind of real issue at all prior to pregnancy or in a person who's not pregnant. But when someone's pregnant, of course, we have great concerns about not only the maternal health, the mom, but of course now we're also worried about the baby, the fetus. So I'm going to turn it over to Dr. Sunny to hear what he has to tell us about that.
Great, thank you. I think you said it basically, but in most people's minds that heart disease and pregnant women don't go together. Most people don't put that together and think, generally speaking, that pregnant women are otherwise healthy. But certainly with women getting pregnant at a later age nowadays versus, say, 20, 30 years ago, there are issues that crop up, and we certainly see things more. And so it's still, like you said, not a very common problem. At tertiary care referral centers for obstetrics, it still makes up less than 1% or approximately 1% of their patient population have cardiac issues. So that's not a lot, but warrants us, you and me, and cardiologists thinking about it periodically and being aware of it. I definitely see people in my office referred for, more often than not, benign things, a palpitation or a flutter or someone hears a murmur, and by and large, almost all the time, they're benign things, but every once in a while, you see something that's not. So I thought it'd be useful to review that. And there are a lot of potential issues or problems for women of childbearing age who have heart disease or who develop it. Lots of things to think about. In no particular order, people depending on what type of underlying cardiac condition you might have, people sometimes have to think about whether it's even safe for them to conceive at all. If there's issues with, whether there should be contraception involved or not, how risky is a pregnancy for them or for the fetus, or passing on whatever disease state one has to the fetus is a concern or issue that comes up. Should one have surgery to correct whatever's going on before considering conception? Etc. If I get pregnant, what type of complications will I have during pregnancy, and will they be permanent afterwards? So lots of things to think about. And I think a lot of in my reading on the matter, a lot of people have been fairly critical of cardiologists or physicians in general to not preemptively address these issues with their patients who have congenital heart disease, meaning heart disease from childhood, and maybe not talking about this early enough, waiting until someone gets pregnant and then all of a sudden having the discussion probably isn't the best approach.
I often think about this subject when I begin to think about cardiology issues and pregnancy, and I do wonder how much of those things that we read about often in history of a mother dying at childbirth or during pregnancy, how many of those were really, in those days, undiagnosed cardiac conditions. And I think that's really the main focus, because it's not common, of course, fortunately, that we have maternal death during either pregnancy or at the time of delivery. And I think that's largely because these things are picked up. So that's the rationale for doing this.
Absolutely. Yeah, so absolutely. And I think what often leads to the problems, we're going to talk about all the different conditions. What I'll end up doing today is talk about all the different conditions, congenital heart conditions that can pose a problem in pregnancy, but then also some things that can occur during pregnancy. So you go into the pregnancy without having any history of anything, and then there's some things that can come up. Rare, but things that can come up. So we'll talk about all those things. And what leads to the problems with pregnancy are the fact that there are certain physiologic changes that the body undergoes during pregnancy. Normal things that happen during pregnancy, the blood volume increases, the mass of the red blood cells in the blood increases, heart rate increases often, blood pressure can actually sometimes drop. The cardiac output, that's what your heart's pumping forward into the body, that increases quite a bit. So there are certain conditions where those issues can have a negative effect, or in some conditions, actually, you might feel better during pregnancy as a result of some of those changes, too.
But all of those are increased stresses on the system, basically, which is what we know. I mean, it's common sense that when a woman's carrying a child, the body is stressed.
Yeah, it's doing extra work, and it's a simple way of thinking about it, that the heart's got to work harder to take care of the fetus and the mom.
So if it's a completely normal heart, probably no problem. But if it has some issue, as you said, that may have been not a problem prior, this may bring it out?
Yeah, there's definitely issues of that where certain conditions can be unmasked, I guess, if you will. It brings it to light, certainly. And interestingly, there are some conditions where, although they're interesting or significant issues, this doesn't really do much to you, and you do okay. And so we'll talk about that. Some people with congenital heart disease, depending on what it is, fare very well through a pregnancy, but there are certain ones that are very high risk.
Okay.
Very high risk, and we'll talk about that. And the general, obviously it's a personal decision for somebody to get pregnant or not to get pregnant, but there are certainly certain conditions where physicians across the board unanimously recommend that one consider not conceiving because the risk of maternal death is so high. And again, people still say, well, I'll still go do it anyways, and that's fine. But as long as you educate people, they can make their choices. And so some of those conditions, one is pulmonary hypertension. So what's pulmonary hypertension? I'm trying to think of the best, quickest, simplest way to explain this. There are pressures inside the heart and in the blood vessels that lead to the heart and to the lungs, and there's arteries that go to the lungs that the pressures can elevate for a lot of different reasons. But when that's the case, if somebody has this condition called pulmonary hypertension or primary pulmonary hypertension, that really bad things can happen during pregnancy. It's got the highest rate of maternal death. Anywhere between 30 to 50% of moms with that condition who get pregnant will die during the pregnancy. That's a very high, that's as high as it gets. I mean, that's a very high rate. And so that's an issue. Now, with pulmonary hypertension or these high pressures, there are certain shunts that can occur in the heart, little holes in the heart where blood can flow the wrong way. Whether you have that or not, it's still a very bad thing to have pulmonary hypertension and get pregnant. But those shunts don't help either. There's other conditions, one called hypertrophic cardiomyopathy, which can obstruct the heart's ability to pump blood out efficiently. That's an issue and can be fairly high risk if you have advanced obstruction to block that. There are certain conditions, or certain shunts and defects that lend somebody to have low oxygen levels, and so they'll sometimes have blue around their lips here. They're chronically running low. If you were to measure their oxygen levels, it's very low. Those folks don't fare very well with pregnancy either. And there's another type of condition that really has a wide spectrum in how severe it can be, and it's called Marfan syndrome. Now, some people may have Marfan's, and no big deal, but there are certain features of Marfan's that can be an issue. And what is Marfan? So Marfan's it's a connective tissue disorder that can lend itself to have problems with the aorta. We think of people who are often very tall, their wingspan is greater than their height. A famous person in history who's thought to have had Marfan's is Abe Lincoln. And people with Marfan's, they can have a problem with their aorta. That's the main artery of the body, where the walls of the aorta can weaken, be more prone to tearing or rupturing, and they can be dilated. And that's a very high-risk situation as well. So those conditions I just laid out, the general recommendation is, if you got those, to either fix something surgically or to not consider conceiving at all.
Okay. So those are the ones that we have to really worry about. Are there ones that we can be more comfortable with, that people who have, women who have congenital heart abnormalities that are less severe, that we can expect a good outcome with pregnancy?
Yeah, absolutely. And that's an important point, because for the most part, those conditions we just laid out, they're pretty rare. And most people who have some sort of congenital heart problem, they do very fine. They do just fine, and just maybe require a little bit of extra attention or what have you. But for the most part, people do just fine. Congenital heart disease is a blanket statement that covers a lot of different types of defects, whether it be valvular defects within the heart, shunts or little holes in the heart, or different ways your arteries are attached in your heart. So it really is a broad spectrum. But for the most part, women with congenital heart disease can do well, and it's a growing population as you could probably expect. As technology's improved, medicine's improved, people with congenital heart disease are now living longer and full lives, and so that population is growing tremendously, and getting to childbearing age now, where maybe 20, 30 years ago that did not happen. So it's something that we have to be aware of, certainly. Actually, I think there was just a big discussion about this very fact at the recent big heart meetings that took place. For the most part, a simple way to think about it is women who have a congenital heart defect that does not lead to low oxygen levels or this bluing around, we call that cyanosis, they tend to do pretty good with pregnancy. But people who have issues with low oxygen levels, cyanosis is the phrase we use, they sometimes don't do quite as well and may decompensate, as a phrase we use, as the pregnancy progresses. Those who have little holes in the heart, little shunts we call them, where the walls between the left side and the right side, either in the atrium or the ventricles, if they're small, they generally do very well and do fine. Those with larger ones who have issues with oxygenation levels might have some issues as the pregnancy progresses. There's also an issue of people with valvular heart disease, so leaky valves or valves that don't open quite as well. They can have issues as well. One thing that's interesting is the issue of rheumatic heart disease. We don't see a lot of rheumatic heart disease in this part of the world anymore, for the most part, because we have antibiotics that are used in childhood and it can take care of strep infections, and so we don't see a lot of rheumatic heart disease. But for patients who have immigrated, it's a lot more prevalent, and sometimes pregnancy is a time where it actually unmasks or helps us diagnose the presence of rheumatic heart disease, and that is the mitral valve can often be affected where it doesn't open as well. It's called mitral stenosis, and we can see that with rheumatic heart disease. And that's actually an important issue during pregnancy that needs to be thought about. Other issues now, I mentioned earlier that women are getting pregnant at later ages now compared to 20, 30, 40 years ago, certainly. And we're seeing people develop coronary artery disease at a younger age nowadays as well. And so we're now seeing women come to pregnancy who have had coronary artery disease, who've had stents put in, bypass surgery even, and that's something that I don't think people thought much of 20, 30, 40 years ago. But that's becoming an issue now. And by and large, if well treated, those patients can do very well with the pregnancy as well.
So is there a way to figure out who's going to do well here, like a way to know by prediction who's likely to sail through and not sail through?
There is. I mean, for the most, to start off with, whether if someone's got one of those real severe conditions I talked about at the beginning there, they may not do well. But yes, there are scoring systems that have been developed through big, large studies to look at who is at risk to have either an event for the mom or a bad event for the baby as well. And real simply, it's a 4-point scoring system. You get a point for each one of these. One, if you've ever had a stroke, a TIA, a heart attack, or an arrhythmia, a bad arrhythmia, that's a point. If you've had this cyanosis or low oxygen levels or can't function as a result of it, poor functional class, there's a scoring system we use for that as well. That's a point. If you have the phrase that's used as left heart obstruction, but where the heart is structurally such that blood flow coming out is impeded because of a mechanical obstruction, that's a point. And if you've had a weakening of your heart muscle, cardiomyopathy is the phrase we use for that, that's a point. And it's a pretty accurate scoring system. So if you have 0 points, you got none of those, you're a very low-risk individual. The chances of something bad happening is less than 5%, which is still a number, but it's low. If you got 1 point, they call it intermediate risk. It's 27%. And if you have more than 1 point, so if you have 2, 3, or 4, that risk is very high, 75% chance of something bad happening. And in this study, all the deaths that took place occurred in people with more than 1 point. And so there is a scoring system, and I think it's useful to, some of that is common sense to us, that if someone's had these events before, they're going to be at high risk, but sometimes it's useful to put it down in a scoring system.
So you've talked about some really advanced congenital heart disease problems, like holes in the hearts, the way the heart for the mom was formed abnormally. And oftentimes, in our area in Massachusetts, many of these patients are followed at advanced congenital heart disease centers. So we don't even really take care of those patients. They're already being taken care of by a specialist in congenital heart disease. Yeah. But talk a little bit about some more common things that we do see in our community. Yeah. So like a person who has high blood pressure, and then gets pregnant. How do you handle the medicines and the high blood pressure, as an example?
Hypertension, by far, is the most common cardiac complication, if you will, if you want to call it cardiac or cardiovascular complication. By far, number one, most common thing. And it can be one of two things. It can be one, somebody who has pre-existing hypertension or pre-existing high blood pressure. They get pregnant, and in some cases, the blood pressure can actually get better for a little while based on some of the physiologic changes that the body undergoes. And so often patients can be tapered off of their medicines and may not need it during pregnancy. But in some people, because of hormonal changes and other things, there can be large spikes in the blood pressure. And if that's the case, antihypertensive treatment, blood pressure medicines, are recommended during pregnancy. And there are certain ones that are used more often than others. If this is something that's brand new, it occurs during pregnancy, no other complications with the blood pressure, the drug of choice is something called methyl dopa. That's been the most extensively studied. It's thought to be it's known to be safe, I should say, not thought to be, it's known to be safe. And so that's the drug of choice for the most part. Now, if somebody's already on a medication such as a beta blocker, so some of those are metoprolol, carvedilol, atenolol, those medicines, generally speaking, are thought to be pretty safe. Now, there have been some reports that atenolol, of all the beta blockers, might not be the greatest one to be on during pregnancy, but the other ones are pretty okay. And so you could continue that. And you may need it for other reasons. If someone's having arrhythmia problems, you may need it. If someone has a mitral stenosis, a valve problem, you may need a beta blocker to help with that situation. And so other medicines are certainly absolutely contraindicated during pregnancy, where otherwise they're generally used for patients. So ACE inhibitors, these are medicines such as lisinopril, enalapril, captopril. They all end in the prils. They are contraindicated during pregnancy. Calcium channel blockers, not necessarily very, like Norvasc or diltiazem or cardizem or verapamil. Usually don't like to use those during pregnancy if you can get away without using them. They actually also high concentration in breast milk, so for breastfeeding, it's not a good drug to be on. Diuretics, okay, but there's some thought that maybe it could predispose one to preeclampsia, which we're going to talk about. And so it's only recommended to use a diuretic if someone that has volume overload or volume excess or fluid retention, but not to use it for general blood pressure treatment. And so moving on, with regards to blood pressure, run-of-the-mill blood pressure during pregnancy usually can be handled pretty well, but there's another condition called preeclampsia, and that's with high blood pressure and problems with the kidneys where protein is being lost. And that's a problem. And that generally occurs, if it does occur, week 20 and onward, and requires a lot of attention and treatment. And the best treatment for it is delivery, but you have to sort of weigh the timing of that, and it's probably beyond the scope of this discussion, but preeclampsia is another issue. Preeclampsia superimposed on somebody who's had high blood pressure prior to the pregnancy, even greater risk, and absolutely needs to be treated. And then there's people who just develop high blood pressure during pregnancy, and then it goes back to normal postpartum, and they tend to, going forward, do well for the most part afterwards. And that's blood pressure in a nutshell. There are some other significant things for us to talk about during pregnancy that can either develop during pregnancy or just afterwards. One of them is something called aortic dissection. Aortic dissection is a problem that I alluded to earlier, where the aorta, that main artery of the body, the wall that can tear, and that can be a major problem. So people who have Marfan syndrome, they're at more risk for that tear because of the genetic defects that you see with Marfan syndrome. And so that's a big deal. And if the tear is in a certain place, surgery is it's a surgical emergency. You got to operate immediately. If the tear is elsewhere, you can sometimes manage it medically. And there's lots of reasons why you can do one or the other. But the aortic dissection is an important thing. Something that I certainly saw in my training at a tertiary care downtown medical center is this condition called peripartum cardiomyopathy. And that's where a woman towards the end of the pregnancy, close to delivery or right after delivery, can develop a really acute or sudden weakening of the heart muscle called cardiomyopathy, and can present with really bad congestive heart failure. We've talked about congestive heart failure on the show numerous times. Bad fluid retention, the heart pump is failing, and people can be really sick. Some people aren't. You can manage them very conservatively and get them over it with medicines. But some people get so sick that this is a condition that could sometimes get someone listed for a heart transplant, or some people may even need a mechanical assist device as a temporizing measure, as a bridge to transplant or as a bridge to recovery. And I've certainly seen that a few times. The incidence in the Western world of this is about 1 in 15,000 pregnancies. It's much more in other places. I came across a statistic that in Haiti, the figure is 1 in 350, and that blew me away. That's a large number. And in South Africa, it's 1 in 1,000, also a large number. So it's important for us to be aware of it and to make note of it. Those who have had it and have recovered are at very high risk for recurrence of the problem, and there's a lot of counseling that goes into that. as well. And often, though, people do well with just our standard medications that we use for cardiomyopathy. Moving on, there's another condition that doesn't occur as a result of pregnancy, but sometimes can manifest itself during pregnancy, and that's hypertrophic cardiomyopathy, or HCM is often referred to as. And people who have this mechanical outflow obstruction coming out of the heart, where the body may not get the blood that it needs, sometimes pregnancy can unmask it, and it can be a problem and difficult to manage as well. And people can be prone to arrhythmias as well as a result of that condition.
Speaking of arrhythmias, that seems like a common thing that cardiologists in the community are consulted on, is irregular heart rhythms or some kind of heart rhythm abnormality. What's the story with those?
And that's by far the most common thing I get in my office, is people who are having palpitations during pregnancy. Brand new, never had it before, and it's very common. And what it generally is due to, you got to make sure that this is what it's due to, but generally it's due to simple extra beats coming either from the lower chambers of the heart or the upper chambers of the heart. And we refer to those as PVCs, premature ventricular contractions, or PACs, premature atrial contractions. Generally speaking, for the most part, they're benign, and some of the stresses of the pregnancy can just bring them on. Often, other things can bring them on in a non-pregnancy, caffeine, stress, concurrent illness, lack of sleep, fatigue. These things can sometimes trigger them as well. There's some simple things that we do to evaluate this in the office. We'll often have someone wear a monitor for 24 hours or 48 hours called a Holter monitor. That's a good way to really document what's going on. And sometimes, if appropriate, we can do an ultrasound of the heart called an echocardiogram, if it's appropriate, to make sure the heart is structurally normal and that you don't have one of these other structural heart abnormalities, some of the valve problems we talked about, the cardiomyopathies or hypertrophic cardiomyopathy. So an EKG is useful as well.
Okay. So, but if you do find an rhythm that's abnormal, that normally we would just handle easily with a medication that we're quite familiar with, what would you do in pregnancy? What medication options are there?
Yeah, I mean, I think for the most part, if someone's having these benign PVCs or PACs, just these extra beats, and not to imply that they don't feel anything, but for the most part, we manage those conservatively. A lot of the times, just reassurance that this is not a problem, this is normal, we see this, nothing bad's going to happen to you from it, it's just a nuisance. For the most part, those folks don't take any pills, don't need to, they do fine. And some people who have other arrhythmias, such as SVT, supraventricular tachycardia, that's where it's a sustained fast heart rhythm. It can go 150, 180, 200 beats per minute. That's not good. We don't like to leave that alone. If one of those patients end up in the emergency room, there's a medication that we give intravenously called adenosine. That's perfectly fine to use during pregnancy. Safe, no problem. So we do that. Can break that rhythm and no problem. But then going forward, we often give medicines to prevent recurrence of those arrhythmias. And the beta blockers, so metoprolol, toprol, Lopressor, those are some of the names you might hear. That's okay. That's good to use. And another one called digoxin. It's been around forever, and it's also relatively safe during pregnancy. I mentioned before the calcium channel blockers. We try to avoid those. Those are cardizem or diltiazem. Try to avoid those. It can sometimes be done if it's absolutely necessary. Another medicine that we sometimes use for the life-threatening ventricular arrhythmia is called amiodarone. We try to avoid that. That causes problems in the fetus. So we try to avoid that medication.
Any comments about one of the things that we talk about frequently on the show is the issues about blood thinners in treatment for different heart issues? What are options that are available for a woman that might develop a clot or need blood thinning because of some other heart condition?
Yeah, that's a complicated issue. And I came across a statement that one expert said, and I'm going to look, he said, quote, there is no good treatment. There are only choices, and there are upsides and downsides for each choice. So you really have to tailor this to each individual and what their needs. So there are the vitamin K antagonists, such as Coumadin or warfarin that we've talked about. And these medications are often given to young women or always given to a young woman who's had a mechanical heart valve put in, or if somebody has had a recent or a prior pulmonary blood clot in the lungs, or if they have what's called a hypercoagulable state. There are certain genetic conditions that may predispose you to clots. And these are sort of higher risk individuals that do need blood thinning with Coumadin. Now we know that Coumadin is perfectly fine for the mom, no issue there, but it crosses the placenta and may be teratogenic or cause problems to the fetus. And so we have historically thought that it's contraindicated during pregnancy. and so you can't take it. But it's complicated. So then what do you do for someone who's got a mechanical heart valve, for example? There is an intravenous medication called heparin, which works, but it's a continuous infusion. And so that's a difficult...
So you have to walk around with an IV pole for 9 months.
Yeah, right. So, that's a difficult logistical issue, and how to handle that and how to do that. You can't be hospitalized for the whole time. And I think there are issues where you can have pumps at home and do it at home, but long-term heparin infusion can cause problems as well that we could take into consideration. And there's emerging data to suggest that a strategy of using heparin, intravenous heparin, during the first trimester and then converting to low-dose Coumadin during the second and third trimester might be an option. I got to say that was a new thing to me. I've always just avoided it altogether with the Coumadin. That might be a possible strategy in the future for some people who are high risk. There are these other types of heparins called low molecular weight heparins, or injections. Lovenox is a commonly used one, and there's a lot of excitement about that because it's an injection twice a day at home, and for a while, and even I think now, it continues to be the treatment of choice for people who need some sort of blood thinning during pregnancy because there are no issues to the fetus. But there's not a lot of data to tell us whether it's a good strategy or whether it's bad, whether problems can develop. There's been some reports of women with mechanical heart valves having clots on the valves using this strategy. So, like that cardiologist said, the expert said, there are no good choices, but you have to make a choice and weigh the pros and cons and benefits of each choice.
Well, that was quite a tour de force on a variety of topics. You handled some really complex issues in congenital heart disease, and you put on top of that the very complex issue of handling it with pregnancy, with great concern about both mother and fetus, really treating two patients simultaneously. So I think the message that I'm taking is this is a tough situation. There are some things like high blood pressure and irregular heart rhythms that are probably very well handled by community-based cardiologists like us.
Yeah.
There are some things that are clearly out of our realm that need to be handled at tertiary care centers that have expertise in congenital heart disease and pregnancy, and then some middle range stuff.
There at those centers, a whole congenital heart centers with a multidisciplinary approach where high-risk obstetricians work together with the cardiologist, and so that's the ideal situation for someone for those patients. So.
Great. Well, I want to thank Dr. Srivastava for taking on a complex issue, an important one, but hopefully a good introduction for those patients in our audience who may either be or may know someone who has congenital heart disease and is contemplating pregnancy. So I'm not going to sign off. I'm Seth Bilazarian, and I want to thank you from Pentucket Medical Cardiology and Haverhill Community Television. This has been another edition of Matters of the Heart. See you next time.